Good evening. I'm Veronica Kazanjian-Babian, graduate of the class of 1995 and from the Office of Alumni Relations at Thomas Jefferson University. I'm happy to welcome you to this evening's discussion, Don't Get Burned, A Guide to Skincare. Tonight, our speaker, Dr. Matthew Keller, will share skincare tips on self-checking, early recognition of skin damage, and ways you can care for your skin throughout the year. During tonight's talk, we invite you to share any questions using the Q&A button at the bottom of your screen. If you don't see the button, try moving your cursor and it should appear. We will address questions at the end of the presentation if time permits. And now, it's my pleasure to introduce tonight's speaker, Dr. Matthew Keller. Dr. Keller has his medical degree from Thomas Jefferson University from 2005, completed his residency in dermatology also at Jefferson in 2009, and became an associate professor within the department the same year. He is the program director of the dermatology residency, director of the Psoriasis Center, and he has been the associate chair of education for the Department of Dermatology since 2017. Dr. Keller is also the immediate past president of the Sidney Kimmel Medical College Alumni Board. Thank you for joining us, Dr. Keller. The floor is yours.
Thanks, Veronica. I appreciate it, and welcome everybody tonight. Let me go ahead and share my screen here. Okay, so again, I'm Matthew Keller, and I'm going to talk about Don't Get Burned, A Guide to Skin Care. We're going to talk about, I have no conflicts of interest. In fact, I joke when I do these talks that it's a conflict of interest for me to try to get people to prevent skin cancer because economically, dermatologists make a large majority of their income cutting out and diagnosing skin cancer. So I guess that's the only conflict of interest I have. So we're going to start with an introduction to skin cancer. We're going to talk mostly about the most common 3 skin cancers that you see. And these make up 97 or 98% of all skin cancer. Guidelines for screening and prevention. And we'll talk a lot about sun avoidance, sunscreen, protective clothing, vitamin D. And then we'll talk about skin health, some cosmetics, moisturization, things like that. I'm also going to leave, hopefully, plenty of time for some questions at the end. So that we can talk about it, because I find when I do talks like this also, it's nice to be able to address questions directly, especially those that apply to a large majority of the audience. So we'll start by talking about malignant cutaneous neoplasms or skin cancer. There were 2 to 3 million new cases per year throughout the early 2010 to 15 or 16. I think that number is probably north of 3 million. The reason it's hard to pinpoint is because basal cell carcinomas, which make up probably somewhere around 65 or 70% of cancers, are not reportable. So these are estimates based on billing and other things like that. Squamous cell carcinoma makes up the majority of the rest of skin cancers, with melanoma being third, but only makes up about 5% of all skin cancers. So basal cell cancer is not only the most common skin cancer, but also the most common cancer in the United States and likely the most common cancer on the planet. It's highly linked to sun exposure, particularly blistering sunburns and light skin. It's more prevalent in older age groups, but it's not rare in those older than 25. So what that means is under 25, basal cell cancer is very uncommon, and outside of a few genetic mutations and other syndromes, you don't really see basal cell cancers. But it's not uncommon to see a patient in their early 30s or late 20s with a skin cancer. It's locally aggressive, which means it grows slowly and invades locally, but it's extremely rare that it's metastatic. And that's one of the reasons why it's not reportable, and why many people live with basal cells for long periods of time without seeking treatment, especially when they're elderly. And I always kid with people that if you're white and you live long enough, you're going to get a basal cell cancer. It's really just a matter of living long enough on the planet. So this is what a classic nodular basal cell would look like. You see this sort of round, kind of, some people could describe it as pearly or shiny sort of bump, and you can see there's some increased blood vessels. Obviously, this patient has a significant amount of sun damage. It looks like they probably had some sort of procedure done in this area as well. So that kind of comes with the territory. This is another kind of basal cell cancer. Again, it's scaly, crusty, scabby, doesn't really want to heal. We'll talk a little bit about basal cell cancer, but as you can notice, both of these are pretty obvious for a lot of patients to notice. This is another less common kind of basal cell cancer, but one that often gets pretty large before it's diagnosed because it's more subtle. And here it sort of looks a little bit like a scar, but obviously there was never any trauma or burn or anything that happened in that area. So what do we look for when we think about basal cell cancer? So the first thing we want to look for is an area that bleeds and does not want to heal. And most commonly in men and sometimes in women, this will be a shaving cut. You know, I thought I cut myself shaving, but it's been 2 months. Every time I shave, I cut the same exact area open. I thought I had a pimple and I popped it. But you know, the pimple just doesn't want to go away, and now it's bleeding and really doesn't want to heal up. A new bump that grows slowly, becomes kind of shiny, sort of looks different than the rest of the skin. You see these very dilated blood vessels overlying it, or a new scar, something that you think is a scar, but you don't remember having any trauma in the area. These are all things that are good to look for when it comes to basal cell cancer. And like I said, the reason that this is important is just because it's so common. It's amazing how many of these people get. So the second most common skin malignancy is squamous cell carcinoma. So with basal cells, those were very, very rare in non-Caucasians. They almost never happen in people with, you know, darker skin, people that don't burn very frequently. Basal cells are very, very, very uncommon. Squamous cell carcinoma is a little more common in people with darker skin than basal cell cancer, but still relatively uncommon. It does have metastatic potential, just like all other squamous cell carcinomas that you may have heard of in the lung or in the cervical area. There's lots of squamous cells found throughout our body, and all of these can obviously be metastatic and go other places. And the reason that, you know, squamous cells can go places is because squamous cells exist lots of places. Basal cells only exist within the skin. And melanocytes that cause melanoma are cells that really can go everywhere. So when we think about the ability of a cancer to go other places, it really is a matter of what did that cell start as. So if that cell started as something that's meant to live only one place within the body, it's far more challenging for it to go other places than if that cell can easily be present within multiple organs. It's related to chronic sun exposure for a lot of patients, and immunosuppression is incredibly important in squamous cell cancer. So as I talked about, basal cell cancers are much more common than squamous cell cancers, probably somewhere on the range of 8 to 12 to 1, depending on the patient population. But when you are immunosuppressed, that relationship flips. It becomes actually 3 or 4 times more likely for you to get a squamous cell cancer than a basal cell cancer. And the reason for that is because immunosuppression or immune surveillance within the skin is incredibly important in preventing squamous cell cancer. And that's because many, probably more than we're really aware of, squamous cell carcinomas are probably related to wart virus or human papilloma virus, which I think many of us are accustomed to hearing about when we think about cervical cancer or anal cancer. Certain types of laryngeal cancers can be wart induced. You also can see that in the genital area, as well as underneath the fingernails, believe it or not, is an area where people will often get obviously wart-induced squamous cell carcinomas. And this is another reason why squamous cell carcinoma is uncommon, but not rare in people with darker skin tones. And that's because they can get wart-induced squamous cell carcinomas. So this is a classic squamous cell carcinoma. What this stuff is over here is actinic keratoses or sun damage spots. I tell people to think about these like areas where you've had enough sun exposure to cause the skin to go funny, but not enough sun exposure to cause the cells to be overtly cancerous. Okay, so they're on their way, but not there yet. This is obviously the skin cancer here, and we can see it's sort of like a crater in the middle with a big crusty spot. This type of skin cancer is very common in chronically sun-exposed areas. May or may not be wart-induced, but it's definitely involved with chronic sun exposure. So I tell people to think about these precancerous lesions kind of like weeds, right? So in your yard, you don't really want weeds, right? But they crop up. So what we do is we go around and we spray them, which is the equivalent of picking them when you think about weeds. This is another common location for squamous cell carcinoma on the lip. A lot of patients will say, oh, I thought I burnt myself. I thought I bit my lip. I thought I smoked a cigarette down too far, because cigarette smoking actually increases your risk of squamous cell carcinoma on the lip. Same thing with chewing tobacco. because the carcinogens obviously are in greater contact with that area of the skin. So I always tell people, if you have a cut on your lip that just doesn't want to heal, and that's a resounding trend that you'll hear from me throughout the night about skin cancer, is spots that don't want to heal or spots that need to be taken a better look at. And then here is a person who's had very, very chronic sun damage, where the skin cancer is essentially probably multiple ones have coalesced into a large plaque that's involving a large portion of this woman's arm. Now, luckily, this is not particularly thick. This is a thin skin cancer, so oftentimes we don't need to do surgical therapy for this, unlike the other two that would absolutely require some sort of surgical treatment. So what do you look for as far as squamous cell carcinoma? So a scaly area that you thought may have been eczema, or you thought it might have been a scratch or a cut, and it just doesn't want to go away, especially here tender. So basal cells can be tender, but they're more likely asymptomatic outside of bleeding. Squamous cell carcinomas, there's a much greater immune response to those, and they are much more likely to be sore or tender. A wart that grows and doesn't respond to treatment, especially if you think you had a wart around your mouth or a wart in the genital area or underneath the fingernail or around the fingernail area, and you say, boy, you know, I've treated this for 2 years now and I can't get it to go away. Those are things that definitely require a biopsy to rule out squamous cell carcinoma. And then one of the rules of thumb I also have is any scaly, painful area that doesn't resolve within 3 or 4 weeks. Obviously, we all have had bad cuts on our legs that take longer than 3 or 4 weeks to heal. So you have to modify that. But something that just doesn't look like it's going the right direction in an adequate fashion. And we see a lot of people from wound care who have chronic wounds that are eventually sent to us for a biopsy. And not all of them have skin cancer, but many of them do. So I always tell people, if you have a wound that just doesn't want to heal, it's not, no matter what you do, you're setting it up effectively and you don't have a good reason why it won't heal, it's very possible that it could be a skin cancer. So melanoma, so this accounts for less than 5% of all cutaneous malignancies, but it's the largest cause of skin cancer death. So, you know, melanoma makes up less than 1 in 20 skin cancers, but makes up probably 75 or 80% of the skin cancer deaths. It's most common in fair-skinned individuals, but it's not even really that uncommon in non-fair-skinned individuals. So we went from basal cell, which is incredibly uncommon, to basal cells that are not that uncommon, to melanomas that are not really uncommon as well at all when it comes to percentage of skin cancers that make up population. So incidence of melanoma is definitely increasing worldwide, and the risk of invasive melanoma was 1 in 62 in 2006. From 1935, it was 1 in 1,500, and it's probably closer to about 1 in 50 now. It's probably going to be somewhere around 1 in 25 by 2035. Now, the reason for this is a few-fold. So one, obviously sun is becoming a bigger issue for people. We have much more leisure time, and though people have spent a lot of time outside, a lot of patients that I have now, it's funny, they're not farmers, so they're not getting that chronic sun like you would with a squamous cell carcinoma. What they are doing is they're playing golf on the weekends, they're going to the beach for a week in the middle of December, and they're getting very badly burnt. So instead of building that base, and not that a base is good, but it does prevent blistering sunburns, which are incredibly important in the development of melanoma and basal cells. The second thing is people are living longer. So, you know, in 1935, people didn't live as long as they do now. So the more years you spend on the planet, the more opportunities you have to develop a melanoma or a basal cell or a squamous cell. So skin cancer is definitely on the rise. We're also better at diagnosing nowadays. So more people, the cause of death is elucidated, as opposed to in 1935, someone would die and they just figured, oh, he had cancer, and no one looked very far into it. So again, it's more common in lighter skin types, but it's found in all races. And believe it or not, in patients with particularly dark skin, acral lentiginous melanoma, and I'll show you one of those. So a mole or a melanoma on the foot, most commonly, is the most common type of melanoma in those darker skin types. So there's no doubt that white people get more acral lentiginous melanomas than African American folks. But when you look at the percentages of where the melanomas are, African Americans are much more likely to get it on the sole of their foot. Melanomas can be slow growing, and you hear about those people that had a mole for a really long time. It started to look funny. Eventually it was biopsied. It was a melanoma and people did great. that's the most common kind of melanoma, the most common course. But then you also hear about the 24-year-old that had a mole, it was biopsied, and 5 months later they were dead. That's just the difference between the biologic behavior of one melanoma and another. The other thing that's important is that though most melanomas have black aspects to them, they're very dark in some area, not all are. So it's important to remember that, you know, anything that's growing and changing in a significant fashion on your body really needs to be addressed. So when we think about it, you know, there's these A, B, C, D, E rules. You know, A is for asymmetry. So, you know, can we fold the mole in half and does it look the same on one side as the other? Is the border irregular and notched? Does it have multiple different colors within it? Is the diameter bigger than a pencil eraser? And then E, people use for evolving or changing. I like E for everything else. So is it itching? Is it bleeding? Is it doing something funny? Is it sore? It just doesn't make sense. So here are some pictures of melanomas I'll show you. So obviously we can see here that there's these dark bumps and globules. There's this one part that looks like an island separated from the rest of the mole. This area is pink with a bump in the middle of it. That's obviously not really symmetrical no matter what you do. It's notched and curved and there's a little area that looks like it's running away. That's not a normal mole. Here is a melanotic melanoma. So these are always scary as a dermatologist when you diagnose these. We can see the very hint of what was probably the normal mole with this big thing coming out of it. That's not good, nor is it normal. Here's an example of something called lentigo maligna, and this whole area here is likely melanoma. Probably melanoma in situ, which means it's not invasive, but it obviously requires a large surgery to remove, and these are very common in very old folks. So people typically over the age of 85 or 90 will often get these, although they may have been growing for a long time. They don't become noticeable until then. And it's really from chronic sun exposure. Here's an example of a melanoma under the fingernail. So a lot of people have brown streaks on their nails, but a couple things that you want to look for here is that one, the pigment is in the skin part, not just under the nail, but in what we call the nail fold. And if you look at how wide it is here versus how narrow the band is up here, over 12 months, because that's about how long it took, this lesion tripled in size. So we know that's the way we know that the nail is growing, because it's shaped in a wedge. Here's what I was talking about, an acrolentiginous melanoma. So this is a mostly flat black area that's almost like a triangle. Triangles don't happen in nature, with this blue-white bump coming out of the middle of it. Okay, and this is obviously a very large and probably very thick melanoma. And patients often do poorly with these because people don't check the bottoms of their feet very often. Many patients aren't really able to see the bottoms of their feet. They literally aren't flexible enough to do that. So that's one of the places I always look, and I have to be honest, I've diagnosed very few acrolentiginous melanomas in my life, but I look there on every patient because one, it reminds them to do so, and two, a lot of my patients can't. So what can you do? What do you do about skin cancer, right, outside of going to the dermatologist? So the first thing I tell people is do a monthly self-check. So my joke there is check your birthday suit on your birthday. Okay, so whatever day of the month you were born, take a little spin in the mirror, 20, 25 seconds. You're not looking for something subtle. We're looking for something that has grown in a significant way, doubled in size in a month or two. It's growing in a triangle, looks like Cookie Monster took a bite out of it. It's got a black, pink, or white bump growing in the middle of it that you don't remember being there. If you have a family history of melanoma, if you're fair-skinned, especially if you've had extensive sun exposure, you have lots of moles, getting a yearly skin check, probably starting in your late 20s or early 30s, is a good idea. I tell everyone they should probably try to get a baseline check if they fit these criteria before the age of 25, and then every maybe 3 to 5 years until they're maybe about 35, and then kind of really settle down and do it yearly after that. You want to see your doctor for any concerning moles, and it doesn't have to be your dermatologist. Certainly you can show things, especially if your primary care is comfortable with it. Things that are changing, growing, bleeding, you definitely want to get evaluated. Because at the end of the day, no matter what kind of skin cancer it is, early recognition and treatment is the most important aspect for a good outcome. So with basal cells, we're not worried about dying, but morbidity is an issue. Losing a portion of your nose, losing a portion of your eyelid, that's never fun. And with melanoma, obviously catching it while it's in the skin is really the secret to a good outcome. Because though we've come a long way with treatment for melanoma, we're still nowhere near the ability to treat it effectively for the majority of people. So what do I recommend as far as skin checks? So all patients need education, regardless of age, ethnicity. It doesn't matter. You need to know what to look for. So I've given you that today. All fair skin patients, again, should have that yearly skin check starting 35 to 40. Again, it doesn't matter who that's with. And then darker skin patients, they really probably don't benefit from routine skin checks. If they have something they worry about, they should absolutely see the dermatologist. But just coming in and having someone look at them without significant additional risk factors like immunosuppression from a transplant, they probably don't benefit much from that visit. So again, early diagnosis and treatment is the best defense against melanoma, but the best treatment of all is prevention, okay? And there's controversy. If you look on the internet, there's lots of people out there that will spout enormous amounts of information about whether the sun is good for you or bad for you, what part sun plays in melanoma, and I don't think there's any doubt that it plays a part in basal cell. I don't think there's any doubt that it plays a part in squamous cell, but there are still people that doubt how much of your risk is augmented by sunburns, especially blistering sunburns. I think all you need to do is look at the fact that as trends of what we wear has changed, where melanomas have changed. So women used to get melanomas in their lower legs, and as the mini skirt and bikini bathing suit became popular, now they get them on their upper thighs, they get them on their back, they get them up in their upper chest. So as more skin has been exposed, melanomas have started arriving in locations where they weren't in the past. So I think that's the best evidence we have that that's indeed the case, that sun plays a part, at least in some melanomas. So sun protection. So this is a big question people often ask. What do I need to do? So there is no doubt that SPF 15 is enough for most people for everyday use, okay? The problem is no one applies enough out of their SPF 15 bottle to get SPF 15. So when they do the SPF, they give an average adult 1.5 ounces of sunscreen to gain that SPF 15. So if you buy a 6-ounce bottle of sunblock, that should be 4 applications. And I challenge anyone out there to use a bottle of sunblock for 4 applications. That's 2 days at the beach for one person and run out of it. So no one gets a 15. So that's why I recommend a 30 or a 50. Because if you apply half or a third, you're gonna get that SPF 15. Now, people say, well, 70 or 100, that's ridiculous, and there's a lot out there about marketing. It's not ridiculous in a few circumstances. If you're gonna be somewhere where the sun is very strong, and we're gonna talk about high altitude and skiing in just a second, when you're out on the water on a boat, 70 or 100 is gonna play a role because you're probably gonna get a 30 or a 40 out of those bottles. Maybe up to a 50 out of the 100 bottle, although I don't think anyone applies that much. That's going to allow you probably to go 3 hours and maintain that SPF 15 for the whole time. Whereas if you were to put an SPF 15 on, you'd need to reapply about every 40 to 45 minutes in order to maintain that out on the boat, high altitude skiing. And I don't know many people that are going to stop every run or two and reapply their sunblock. So again, that's when I don't usually ever use 100, but that's when I personally wear 70, is when I'm doing those activities where I don't really want to stop and reapply. And reapplication every 1.5 to 2 hours is important. And again, like I said, if you're at the beach and you're in the water, you need to reapply every 45 minutes, because the sand will literally blast the sunblock off your skin. And that's why sand ends up in your shorts and everywhere. It's because it's in the water, and it's just like sandblasting you. And the other thing I tell people, if it's light outside, the sun is shining. And the clouds actually don't block as much UV as we'd like to think. So patients who have sensitive skin are those who don't want chemicals. So people ask this question of me all the time. So zinc oxide and titanium dioxide products are a great choice for these patients who either they're sensitive, they can't tolerate oxybenzone, they have allergies. There is not a lot of data to show that micronized versus non-micronized makes a difference. What I will tell you is micronized zinc oxide or titanium dioxide, far more cosmetically appealing. Because when it's not micronized, in other words, beaten up, it's very hard to apply, and it makes you appear white like a ghost. And some people don't care. And I tell patients, you can wear whatever you want, but putting zinc oxide that's not micronized on is akin to putting diaper cream on, because that's exactly what diaper cream is. It usually has a significant amount of zinc oxide. There's also little data that chemicals present in sunscreen now, the ones we use now, retinol palmitate was an issue, but are unsafe from a cancer standpoint. Most data points towards the way most people wear sunblocks being completely safe. Much of the data we have is feeding animals oxybenzone or avobenzone or many of these products somewhere at the level where you'd need to apply full body sunblock 2 or 3 times a day for 35 years in order to get the amount of exposure they had. And even then, we're still not sure that it makes a difference. The one thing I will say is these zinc oxide, titanium dioxide products, though they are very good from a non-chemical standpoint, they do not work as well. So you have to really go over time to make sure you're putting it on thick and reapplying. Otherwise, you won't get adequate because they don't absorb the rays, they actually reflect them. So if it's not on thick enough, you're not going to get the benefit. So I put this up not because I'm a rep for Neutrogena or Coppertone. In fact, this is the Target brand of Coppertone Sport, but these are the sunblocks I use. Okay, so I love Sheer Zinc. It's a micronized zinc product from Neutrogena. There are other equivalent products. I just happen to like this one. All 3 of these, they sell at my Costco that I go to. I don't use the 100. We use usually 50 for these, and this is usually 50 plus. And I like those. This is a stick. My kids like it because it doesn't run in their eyes. I love the spray because I can keep it in my golf bag and it won't blow up everywhere because I can lock the top. This Beach Defense cream, I like it, rubs in well and smells good. I love Coppertone Sport. I think it's fantastic. They also make a spray of it. My favorite thing to use is the Target Compare to Coppertone Sport because it's $1.50 cheaper than the Coppertone Sport, and you can get it in this nice twin pack. So if I'm at Target to buy my sunblock, this is what I get. If I'm at Costco to get my sunblock, this is what I get. And that's really just a matter of, you know, being cheap. But I like all three of these products. And I think you'll find that Consumer Reports most years rates the Target compared to Coppertone Sport as one of the better sprays. So another thing is sunblock's great, but what's even better? Physical protection, okay? So there's a lot of companies out there that make protective clothing, Coolabar, Solumbra, Land's End. Here's the problem. It's not incredibly fashionable. Again, some people don't care. But for those people that do, this is really a disadvantage. So believe it or not, the company that makes that dye that you would use to make tie-dye shirts when you were a kid makes something called SunGuard, and you literally put a box or 2 of this, depending on how large the load is, in with your own clothing, and it is now UPF 30 for the next 10 to 15 washes. So it's a way to make your own t-shirts, your own shorts, your own everything, UPF 30 without having to pay the extra price or buy something that's less fashionable. I always tell people, do not wash your $100 silk blouse in this. That's not going to work, but it's great for t-shirts and other types of clothing like that. So what are some other things we can do other than, you know, that's physical protection, but other than, you know, the things I mentioned already. So if you don't have to do something between 10 and 4 in the sun, don't do it. Mow the lawn at 8 in the morning or mow the lawn at 5 in the evening. You're going to avoid an enormous amount of the sun. In fact, if you look at the UV rating at 8 in the morning, it might be a 2. At 5 in the evening, it might be a 4. And those in between 10 to 4 hours might be a 9, 10, and 11. That's a significantly increased amount of sun. And I don't think people realize, people think about noon, but 10 to noon is actually a very strong time for the UV rays. Wear a swim shirt or bathing suit with UPF. I wear a swim shirt everywhere I go. And my wife often does when we're out on our boat, because it's so much easier not to have to apply as much chemical sunblock to you and have to worry about, did I get my back effectively? Did the wind blow it away? Did it wash off? Buy yourself a beach umbrella and use it. Yes, the rays will reflect off the water. They can come off the sand. They really come off the snow, and I'm going to show you a little diagram about that. So you need to be careful of that and still put your sunblock on. The beach umbrella alone won't help you, but it will help you get rid of a lot of the UV rays. You have to be very aware of high altitudes, and because less humidity in atmosphere allows a greater amount of UV radiation, and that number can be pretty significant. Wear appropriate sun protective goggles or sunglasses, broad spectrum polarized, because you want to protect your eyes. And that's really important as well. So here's a little diagram that I love. So this shows the percent of UV rays that come up off. So grass, spectacular, nothing bounces back up. Sand, actually not that much, between 5 and 25%, depending on how white the sand is. Water, 10 to 30%. We talk about these all the time, sand and water. What we don't talk about is snow can be 40 to 90%. So it's hitting you on the way down, and it's hitting you almost as effectively on the way up. Not to mention, when you're skiing, you're normally several thousand feet above sea level. So if you're at the beach at zero at sea level, right? And then you go to 10,000 or maybe 14,000 feet above, if you're in Breckenridge, let's say at the summit, right? That's 14,000 feet higher. And for every 300 meters, which is about 1,000 feet, okay, so that's 14 times 4, right? That's an additional 56% UV you're going to get, right? So you're going to get 156%, and then it's going to bounce on you twice, right? So it's really important to understand that you're going to get somewhere around 200 to 250% the UV exposure if you're skiing in Breckenridge as you will at the beach, okay? Just by virtue of all those things. So it's really important to think about that. So what about vitamin D? So you don't need to get it from the sun. That's a fallacy. Supplementation works just as well. There's zero data to show that supplemental vitamin D is not just as good as what your skin makes. The problem is we didn't have supplemental vitamin D 1,000 years ago. So if we didn't make our own vitamin D, we wouldn't have had it. There are only a few foods that have significant amounts of vitamin D. Salmon, tuna, mackerel, which I don't, salmon maybe, but not a whole lot of people eat tuna and mackerel, mostly because of mackerel not tasting all that great and tuna having a lot of mercury in it. Beef liver, which people probably ate a lot of in the 50s, but it's less common now. And egg yolks, which a lot of people end up removing those and eating egg whites. So we really don't get a lot in our diet, but what the government has done is put it in milk and orange juice for us. So if you drink one of those products, you're going to get a lot more vitamin D than you would in your normal diet. The other thing to know is that if you're Caucasian and you don't tan in a tanning bed or stay tan year round, 15 minutes or less a few times a week on what you would normally expose outside in the summertime is enough to get all the vitamin D you need. So you don't really need to adequately go outside. People that are vitamin D deficient because of lack of sun exposure are either militant about their sun protection and just keep 70 on themselves year round, or they're people that don't get outside very often, people at nursing homes, people who otherwise are incapacitated, not able to really get outside and participate in activities, and those who tan. The more you tan, the less vitamin D you make. Okay, the other thing is once you hit that 15 or 20 minutes for most light-skinned people, you actually break it down as fast as you make it. You don't keep making it. You hit a certain level that your skin can make, and then that's what it'll make for the day, or at least for that period. So the other question people ask me a lot is, how do I look younger, okay? And how do I stay looking young longer? So the most important thing, and that might be too late for some of us, is wear sunblock and protect yourself from the sun. I'm going to show you a little picture in just a second to show this, but literally the sun is breaking down your skin, breaking down the connective tissue, the stuff that gives it plump, okay, and makes it less wrinkled all the time when you're out in the sun. And you can only repair so much of that. So I tell people, think about taking a rubber band and sitting it on your front dashboard and driving around for 6 months. When you come back and go to use that rubber band, it's going to literally crumble in your hands. Well, that's what all the elastic tissue in your skin is doing when you expose it to the sun. The cheapest thing to use for looking young longer is a topical retinoid, like tretinoin, which is a prescription, or adapalene that's over the counter. I think tretinoin's a little better, but certainly this is a reasonable option since the use for wrinkles and anti-aging is a cosmetic one. This is much better than retinol. Do not mistake retinol with retinoid. Retinol is a vitamin A compound that is pretty close to vitamin A itself. It is not very photostable. So you wear it, you put it on, you go outside, and 15, 20 minutes later, the sun has completely broken it down. Whereas retinoids, especially adapalene, are a little bit more sun tolerant and they last a lot longer. The other thing to do is to moisturize with an appropriate moisturizer for your age and skin type. So certainly some people need to use Vaseline, like the petroleum jelly, because their skin is just so dry. Some people, they still get acne, so they need to use something a little bit, less oily, something that's not going to clog their pores. So here's an example of cutaneous aging and the things that can affect it. So this is a 31-year-old girl. She's had 2 melanomas, whether they're related to the sun or not. She's definitely had a lot of sun exposure. So what this is this is a light that removes the upper layer of skin. It does it through the trick of physics. And it shows all the brown spots that she has that are eventually going to come up on her very nice skin right now. All the sun damage, all the wrinkling, all the things that aren't going to be apparent until Genevieve is 50 or 55 or 60. But the damage she does today is what's going to make her look like a handbag, 20 or 30 years from now. Here's a gentleman who drove and his face was always in the sun. And you can see this one side of his face is significantly older than the other side of the face. Not that he doesn't have some deviation, sun aging, but it's significant. And here are two twins. This twin spent her life in the sun. She smoked and drank. This twin is a little heavier, obviously, didn't really smoke, didn't spend much time out in the sun. And you can see the difference. I mean, they look completely different. This person, you can tell that they've smoked. You can tell that they've been in the sun. You can tell all those changes. So it's really important to understand that, you know, it's not just sun, but there's lots of aspects to aging, but sun definitely plays a part. So lasers. So, you know, what are these magic things we use? I don't, because I'm not a cosmetic dermatologist, but my colleague, Dr. Sadie, uses them significantly. What can they do? So what I tell people is the newer therapies are more effective and have less downtime than the older treatments, but they're not magic. Okay, so the most important thing when it comes to lasers is see someone who knows what they're doing. Don't get the Groupon, don't go to the esthetician. I love those people. I'm not knocking them. I'm just saying if you're going to use a high-powered device to do something for your skin, you should go to someone who has spent significant amount of time using those therapies and understanding your exact skin type and what is the right laser for you. So here's an example of something called the Fraxel Dual. It's a new therapy, newish. It's been around maybe about 8 or 10 years that does fractional resurfacing. So any of you who ever knew anyone who had resurfacing done in the 80s or 90s or early 2000s, what they looked like was somebody blew their face off. What this does is it makes micro holes in the skin, and you can see that it's not perfect, but there's significantly less of these dark spots. There's significantly less wrinkling, and these are very, very good photos as far as the profile. She doesn't have makeup on it either. You can see the crow's feet are significantly reduced. They're not gone, but she does look quite a bit more youthful. And I think that's a therapy that's well worth the cost if someone is concerned about that. Here's intense pulse light. This is not a laser. The benefit of this is it can work on both red and brown at the same time. This is something common for younger people to do. This is someone who's probably in their late 20s, early 30s, has significant amount of lentigines or freckle spots, sunspots. And you can see they're not all gone, but there's been a significant reduction in how obvious those spots are. Here's something called PDL. This is pulse dye laser. This is for rosacea patients. So we can see they have significant redness of the cheeks. And it's not gone. They don't look like a ghost, but significantly less red at baseline, okay, with the pulse dye laser. So that's really the laser for people that have redness from rosacea. So what moisturizers should you use? So these are a few different moisturizers. This would be the moisturizer you'd use if your skin is oily. These two would be ones, this is a little bit less thick than this one, but the Olay line I think are very good for anti-aging. If you just wanted a regular moisturizing cream for your body, this would be a CeraVe moisturizing cream is an excellent one, although there are tons of corollaries with Eucerin, Aveeno, you name it, every component. But again, what you'll see here is that these are in pump bottles. They're much thinner, don't put near as much moisture. These are in jars. Jar moisturizer is always going to be thicker, okay? Puts much more moisture on your skin. And these are not elegant. That's a word that they use to say, I gave you 15% moisture in this product and the other thing's 85% water, so it evaporates on your skin, and I'm going to say that's elegant and it soaks in, it dries up. Okay, these are not elegant because they don't dry up. They sit on your skin for a long time and actually give you moisture. So as far as body wash goes, I don't think you have to do anything fancy or special. I don't think there's much to it. Dove sensitive skin, spectacular. You can use the body wash or the bar, it doesn't matter. Cetaphil is a great cleanser for the face. These micellar cleanser is excellent. If you have very dry skin, it's actually, they take all the soap part out of the soap and only leave the oil and dirt removing component. And it really literally goes on like water, but it actually removes all that oil and dirt. It's actually an amazing product and quite cheap. So tips for life and skin cancer, I'll end with this. So live your life, but live it with moderation. Okay, so I am not one of those dermatologists that yells at my patients if, you know, they say they golf every day or they come in with a small sunburn. I understand that that's life and you have to live your life, and it's not worth not getting skin cancer, living to the age of 90, and at the end of your life realizing you didn't live. But that doesn't mean you can't be smart about it. Don't ignore spots that bleed and won't heal. If your wife or husband doesn't like the spot on your back, indulge them and get it checked. It may just save your life. Take responsibility and check your birthday suit on your birthday. Okay, so thank you very much. If anyone has any questions, I'd be happy to try to answer what I'm able to.
Thank you very much, Dr. Keller, for a very informative session. We just have one question, and that question is, what about for children? Do you have any recommendations as far as skincare, particularly for children?
Yeah, so I think, we'll break that up a little bit into a couple different, aspects. So one, there is, babies. So for babies, you want to keep them out of the sun, especially before the age of 2 months. There's just no reason a 6-week-old needs to be out in the sun. But certainly if your child is going to be exposed to the sun, I think the mineral blocks, especially the non-micronized ones, are by far the best over the chemical sunblocks for a lot of reasons. When we think about little kids as far as lotions and things go, I think keeping it as simple as possible is a good idea. I tell people avoid the Aveeno baby products, especially the baby soap. Unfortunately, there's some chemicals in there that a lot of kids can have trouble with, and it can actually give them a rash. That's not a knock on Aveeno baby, it's just there's a preservative in there that's not very good. So I tell people stick to mild soaps. You don't have to use Dreft detergent. For your children. It doesn't get your clothes clean. It's expensive. Use like All Free and Clear or Tide Free. Those are both very good, no dye, no fragrance, washing detergents that actually get your clothing clean. The other thing is most kids between the age of 2 and 12 don't need moisturizer with any regularity unless they have dry skin or eczema. And then things like Aquaphor or thick creams like CeraVe or Aveeno cream are a really good idea. You don't need to use anything with fragrance on kids. Kids don't need deodorant until they go through puberty. They also don't have to bathe head to toe every single day, especially if they have sensitive skin. When your kid starts to get towards puberty, I think the best thing to use for acne to start with is benzoyl peroxide wash. They can use it in the shower. Make sure they use old towels so they don't bleach or good towels. But at the end of the day, it's a really great product to start with. It's not overly drying and it's available over the counter. Most kids, as far as moisturizer goes, that Cetaphil lotion I showed you, I think is excellent because it's non-comedogenic, won't cause acne. So I think that's an excellent thing to use. You also can use Purpose Cleanser. That's an alternative, just so I don't feel like I'm pushing one product over another. Most kids don't need to use moisturizer again in their puberty years unless they have bad eczema. Again, that's a totally different ball of wax. I tell them, your kid's going to want to use Axe body spray or, some sort of fancy, Japanese cherry blossom soap. And it's okay for them to use that once in a while, but realistically sticking to something simple like Dove for sensitive skin or other things like that is going to get them clean, but it's also not going to overly dry them out and irritate their skin. And that's also really important because if they do have acne, we want to let the acne medicines dry them out, not other soaps. Make sure you're getting the benefit from the things you get benefit from. As far as sunblock goes, I think once a kid hits 2 or 3 years of age, you can use the same sunblock on them that you use on yourself. Definitely make sure they have a swim shirt. Definitely make sure they stay under the umbrella. They put a hat on if they're willing to wear one. That's going to protect their face substantially because again, sunblock is great for those areas you can't cover, but if you can cover, it's definitely the way to go. And I think a lot of people feel like, well, I don't want to put my young girl or I don't want to put my young boy in a swim shirt. It's going to make them look funny. But I will tell you what, if you get them ingrained in doing it early, like I did with my kids, it's not a second thought for them to put a swim shirt on. And they really appreciate the fact that they don't have to spray each other's backs and that they don't get sunburned over the summer. I think you're muted, Veronica.
Sorry about that. Thank you for that, Dr. Keller. We'll just ask you one more question before we wrap up. There are further questions and we'll send them to you so you can respond to them directly. What's a good product for acne?
So that's a great question. So, as I said, benzoyl peroxide wash is definitely the first thing to start with. Without a doubt, it's the first thing I tell every child to get started with. It's easy for them to use. Again, you put it in the shower, you let them use it, old towels so they don't bleach it, take the bath mat away so they don't bleach your bath mat. But to add on to that, I think adapalene is a great over-the-counter retinoid that kids can use, especially for whiteheads and blackheads on their face. They can use that on their chest and back as well. Once you get beyond that, I tell people to avoid salicylic acid containing products. Avoid things with scrubby beads. All they're going to do is irritate the skin without giving you much benefit. At that point, that's when you talk to your pediatrician or your family medicine physician, internal medicine physician, or dermatologist about maybe starting like clindamycin lotion or upping it to tretinoin from the adapalene, or even if it gets significant, adding on an oral antibiotic or something else like that. The other thing that's important when it comes to acne is kids need to understand that it takes 8, maybe even 12 weeks to really get the maximum benefit from the medicine. So if they start using the benzoyl peroxide wash and 4 days later they say, oh, I'm still breaking out, you have to really reinforce to them, look, we just got to stick with this because we're not preventing the pimples for tomorrow. We're preventing the pimples for next month, the month after that, and the month after that. And then once they get clear, they have to continue with that treatment to stay clear. And that's why I think benzoyl peroxide wash is such a great product, because it's in the shower, so they see it. They're going to wash themselves hopefully anyway. So it's very easy for them just to reach for that as opposed to reaching for their body wash.
Fantastic. That's great. So that's going to wrap up our evening. Thank you again so much, Dr. Keller. We really appreciate your time. And thanks again to everyone who attended. As I said, we do have some more questions with Dr. Keller. We'll forward them on to you as well. And so we just wanted to also let you know that we hope that you follow us on our social channels, and check out our Future Fridays, which is our alumni career tips that we will have every Friday through July 3rd. And I'll just share that with you right now. And also look for more exclusive webinars for our Jefferson Textile and PhillyU alumni, including a talk planned for June 24th on designing communications for the pandemic. Registration will open soon for that event at jefferson.edu/alumni events. And also, during this challenging time, we are asking our alumni and benefactors to help us reimagine the way we educate tomorrow's leaders. You can help to generate additional assistance to lessen the financial barriers that could deter a student from pursuing a Jefferson education. Some of these barriers have been exacerbated by the COVID-19 crisis. By supporting scholarship aid today at giving.jefferson.edu, you can have a lasting impact on our students. Thank you for participating in tonight's talk, everyone. I hope you stay well and stay safe.